All right, so Dr. Kende Elisha speaking here, founder of MP Certification Academy. We're going to first of all get started with immunology labs. But before we even go to immunology labs, let's go through immunology concept and abbreviations that we tend to see and what they mean. And then we'll go through the labs that have been simplified here. All right, so the first thing we're going to go over is what? WBC. That means white blood cell count. Most of us know this one, right? And then what does it do? It measures the total number of white blood cells, high infection or inflammation, low in immunosuppression. So what about CD4 count? It's called a CD4 T lymphocyte count. What does it do? It assesses immune status in HIV or AIDS. It is generally low in advanced HIV. It is generally low. When it is advanced, it is low. What about CD8 count? It's a CD8 T lymphocyte count. It measures the cytotoxic T cells. It helps to monitor immune activity in viral infections and HIV. What about CD4 to CD8 ratio? CD4 to CD8 ratio, T cell ratio, will evaluate the immune function. Low ratio in HIV altered in autoimmune diseases. What about the CRP? C-reactive protein is non-specific marker of inflammation. It is elevated generally when we have infection, autoimmune diseases, and trauma. What about the ESR? That is the erythrocyte sedimentation rate. What does it do? It's supposed to indicate if inflammation is present. Generally non-specific, but it is elevated in autoimmune or any kind of rheumatic diseases. What about the ANA? ANA is called the anti-nuclear antibody. The anti-nuclear antibody generally detects what autoimmune activity. Positive in SLE, S-germ, and scleroderma. What about the anti-dsDNA? Anti-double-stranded DNA antibody. What does it do? It is specific for lupus. It helps confirm diagnosis and monitor disease activity. What about the RF? It's called the rheumatoid factor. Autoantibody seen in rheumatoid arthritis and other autoimmune diseases. Anti-CCP, anti-cyclic citrullinated peptide antibody. It is more specific than RF for diagnosing rheumatoid arthritis. What about IgG, IgA, and IgM? These are immunoglobulin, GAGM, GA, and M levels. It measures immune system function, abnormal infections, autoimmune diseases, and myeloma. What about the CH50, total complement activity? Screens for overall complement system function, low in immune complex diseases like lupus. What about C3 and C4? Complement component C3 and C4, then it's in the individual's complement proteins, low in lupus or other autoimmune conditions. What about HIV AB or AG, HIV antibody or antigen combo, 4th generation? Detects both P4, P24 antigen and antibodies to HIV1 or HIV2, early detection of HIV. What about hepatitis panel? Hepatitis panel, that would be A, B, and C screening panel. They test for hepatitis A, B, and C viruses and immune status, antigen or antibody or viral load. What about quantiferon gold? This is typically common on the exam. Interferon gamma release assay, IGRA. Now, you got to listen to this many times. Get used to seeing them. Imagine walking into something called IGRA on the exam. Are you kidding me? That's a lot to help you freeze, okay? It's going to make your situation worse. So know them now before you get in there. Be familiar with them. I'm recording this now. I need you to listen to this over and over and over again. Speaking as Dr. Kende Elisha, founder of MP Certification Academy, we offer PMHMP, FMP, AGMP, AGACMP, and NCLEX exam review. So, of course, FMP, AGMP, did I mention that? PMHMP as well. And we do both ANCC and AMP. And also, for acute care, we do the AACN too. So now, blood tests to detect latent or active tuberculosis exposure. Now, let's talk about the labs. We are now getting on the labs. Okay, so what do we need to know about the labs, and what do they really mean? What is the clinical significance, and how should we critically think about them? Okay, so you will see me repeating the same things again, but in a different light. I'm shedding more light, right? That's what you're going to see that is different. Now look, with WBC, what does it do? It measures total immune cells in blood. Normal range is 4,000 to 11,000 microliter. What does it really mean? When we have IWBC, it means infection. When we have low WBC, it means immunosuppression. So it's concerning too when your WBC is low. That means that you don't have anything in your body fighting for you. Clinical significance and critical thinking. IWBC, think acute infection or leukemia. Low WBC, just go ahead and watch for chemo, HIV, lupus, and so on and so forth. That means they are immunosuppressed. Let's look at CD4 count. It measures helper T cells, immune strength. The range is 500 to 1500 millimeter cube. When it is low, that means it is weakened. You have weakened immunity. Example, people with HIV, they have low CD4 count. As a matter of fact, less than 200, you got to think HIV diagnosis. You want to start prophylaxis for what? Opportunistic infections, guys. This is going to be on your exam for sure. Now, what about CD8 count? That one is cytotoxic T cells that kill infected cells. What is the normal range? Is 150 to 1000 millimeter cube. It is high when somebody have what? Viral infection. Listen, the CD8 count is high when somebody have viral infection. It is low when somebody have immune dysfunction. So balance between CD4, CD8 ratio helps to track what? HIV normal ratio 2:1. Now, what about the CD4 to CD8 ratio? That one's supposed to help, monitor for what? Immune balance marker. Range is 1.0 to 4.0. Do you really have to know the range? No, it's an entry-level exam. It's just good to eyeball it and be familiar with it, though. But most importantly, how do you interpret your result? When they say something is high or low, do you know what it means? So low CD4 to a CD8 ratio, low is going to be what? Less than 1, and that means what? They are immunosuppressed. The number is low, they are immunosuppressed. So in HIV patients, low ratio is equal to worse prognosis. It's going to only improve with ARTs. So what about the CRP, C-reactive protein? Of course, it's an inflammatory protein, and of course, less than 1.0 milligram per DL means they have a low risk. It is elevated in inflammation, infection, and autoimmune issues. If it is more than 3 milligram per DL, you got to think infection, lupus, RA, or tissue damage. You got to know that for the test. When your C-reactive protein is elevated, it's more than 3 milligram per DL, think infection, think lupus, think RA, think tissue damage. We want it to be less than 1.0. See? Now, it helps track flares. So if you have been struggling with immunology, if you have been struggling with hematology, if you have been struggling with serology, listen, it is because you don't know your numbers and you don't know how to interpret it. That's it. Period. Okay? It is all about numbers. It's all about labs. It's all about interpretation. Now, let's talk about ESR. Erythrocyte sedimentation rates. What does it do? It measures inflammation over time. Less than 20 millimeter per hour, women. Less than 15 millimeter per hour, men. What is I? Chronic inflammation. Not disease specific. Used to monitor chronic autoimmune disorders like RA or lupus. Now, we're going to talk about what? ANA anti-nuclear antibody. ANA anti-nuclear antibody, auto antibodies against nucleus. Now, negative or less than 1 to 40 ratio. Positive is equal to autoimmune, SLE or RA. So, gotta know how to interpret again. Positive is autoimmune. They have SLE or they probably have RA. So, a positive ANA is not equal to lupus. You must correlate with symptoms and specific antibodies like anti-dsDNA before you can conclude on lupus. Now, anti-dsDNA and antibody to DNA negative is what we want. These are just the normal range that we want. If it is positive, it is specific to lupus, period. Okay, that's the way to rule out lupus. Highly specific to SLE. That is systemic lupus erythematosus, used to confirm diagnosis of ANA positive. Now, what about RF? We have rheumatoid factor. You will not know all this in one day. Don't worry, you get to repeat and listen to this over and over again. I'm just presenting it right now. There is no way any human on earth will capture this in just one lecture. Okay? And that's why I'm moving a little bit quicker so that you can actually have the opportunity to listen to it many, many times. That's what's going to take to get this. Okay? Now, rheumatoid factor, autoantibody to IG, negative, less than 15 IU per ml, positive in RA, but also in aging and other conditions. Positive in RA, but when we are old, you're going to see that this may be positive. All right, so that should not be anything to really raise an alarm. And these are things we have to be familiar with on the exam. When they give you a test question, You have to take note of the age that they are presenting and correlate with what you have in front of you. Now, not diagnostic alone, combined with clinical what signs, joint stiffness, and anti-CCP. Now, anti-CCP, that is, what is anti-CCP? That's cyclic citrullinated peptide, specific antibody in RA, negative less than 20 U per ml. Positive, if it is positive, it means it's early or aggressive RA. It's more specific than RF. Early detection is equal to better than long-term joint outcome. So when we discover it early, we can do something about it. IgG, IgA, IgM levels, immunoglobulin antibodies. IgG 700 to 1600 milligram per DL, IgA 70 to 400, IgM 40 to 230. So low, it means we have immune deficiency. I means we have infection or autoimmune disease. Now, low IgG or IgA, you want to suspect immunodeficiency. IgM, you want to think acute infection. So pay attention to that. You have to be able to interpret this. Not the number per se, but that also will help. Okay, it's an entry-level exam. You are not expected to know everything, but you need to know enough to be able to eliminate and connect the dots. Now, what about total complement CH50? Measures full complement system. 60 to 40 units per ml is the range that we want. If it is lower than 60, it's complement deficiency or active autoimmune disease is what that means. It is used in SLE. It is used in vasculitis and decreased during flares. What about C3 or C4 complement? Okay, I know some of you want questions. I hope you get my point. Type yes in the chat if you understand that this is a solid foundation that you must have to even do any questions. Otherwise, we're going to be building on the sand. If you don't understand what all this means, it is a waste of time doing questions. Don't worry. A lot of questions in Canvas under modules and a lot of questions also under quizzes. But I promise you, you need to understand how to interpret. Your question is mostly focused on labs, nothing else. So you got to understand this first. Okay. Now, specific proteins in immune pathway. C3 90 to 180 milligram per DL, C4 10 to 40 milligram per DL. Now, that is what we want. If it is low, we know it's consumption, which means that they have lupus flare. This is not a very, very common test, but it's still good to be familiar with all of these tests though. So in lupus and nephritis, we see low C3 and C4 active disease monitored during treatment. What about HIV antibody or antigen 4th generation? Detect HIV antibodies plus P24 antigen. Negative is what we want. If it is positive, it means there is HIV infection. Positive, you want to order what? Next, you want to do HIV viral load as well as CD4 count. If you see that HIV antibody or antigen 4th generation is positive, you want to go ahead and order what? The viral, that will be a test. Viral load and CD4 count. There is sequence, there is order to things that we do in primary care. You have to know what is next. If you suspect something, you want a definitive test. Okay, now look, hepatitis panel is the next one. It detects viral antigens and antibodies, HAV, HBV, HCV. Depends on what component. It is positive. Positive is equal to infection or immunity or exposure. We want it to be what? Negative. If it is positive, it means there is infection or immunity, or even you've been exposed to it. So use the guide vaccination treatment exposure management. That one is a little bit more broad than this. Okay. So now what about quantiferon B gold interferon test for latent TB? Normally we want it to be negative. If it is positive, it means there is latent TB. Positive, then you want to rule out what active TB. How do you want to do that? You want to go ahead and do a chest x-ray. This is the sequence, okay? You are not doing a chest x-ray first. You're doing what? You're doing a quantiferon TB test first. And then if it's positive, you want to go ahead and do what? A chest x-ray before you start treating them. You got to follow the right sequence. Let's talk about critical thinking pearls. Critical thinking pearls for immunology, okay? So the first thing we're going to talk about here is what? ESR plus ERP. What do you want to think about this? You're going to think of what? Inflammation or infection. You want to correlate with fever. You want to correlate with pain, rash, autoimmune symptoms. What about positive ANA only? It is not diagnostic for lupus alone. You want to look for fatigue. You want to look for rash, joint pain, and confirmatory tests. What about low CD4 in HIV? There is risk for PCP, pneumonia, candidiasis. You want to start prophylactic meds like Bactrim. What about IgM plus fever? You want to think recent or acute viral infection like EBV. Low complement C3 and C4 may indicate lupus flare, immune complex disease, order urinalysis for proteinuria. Now, what about hematology terms? We just finished what? Immunology. Those are immunology terms. What are the terms in immunology? For a quick recap: WBC, CD4 count, CD8 count, CD4 to CD8 ratio, CRP, ESR, ANA, anti-dsDNA, RF, anti-CCP, IgG, IgA, IgM, CH50, C3, C4, HIV, AB or AG, hepatitis panel, quantiferon, TB, gold. Now, a lot of people walk into the test and see all of this, and you are not familiar with it, you're gonna freeze. Okay, so you want to get familiar with, you want to know it like really well. Okay, the next thing we're going to move on to right now, before we start doing questions on this body, on this concept like immunology, hematology, and serology, we're going to move on to hematology. Okay, so now, hematology, what are the concepts? That one should be straightforward. A lot of us know this, we're familiar with this, it's very common anyways. RBC, hemoglobin, hematocrit, WBC, platelet, MCV, MCH, MCHC. And do we have any questions before we go further though? Okay. Before we finish this up, do we have any questions? Please make sure you raise your hand or type your questions in the chat. So anyway, most of us are familiar with this, like I was saying. But by the time you move a little bit down here, then it becomes a little bit of an hiccup. All right, RDW, neutrophils, lymphocytes, monocytes, eosinophils, basophils, retic count, ESR, CRP, ferritin, TIBC, iron, B12, folate. This is your GPS, okay? At NP Certification Academy, we try to build the house for you on the rock, okay? We don't glaze things on the top or just give you common things on the test. I have to take you down to this route first for our questions to make sense as we're about to dive into Q&A on each of these systems concept. You have to understand, first of all, what does it mean? Why are we doing it? What is the normal range? What is the critical thinking application of it? Now, many students didn't have a good laboratory lab experience, or maybe clinical experience, I must say. So our review also kind of take you to that level of clinical, because you still need that clinical skills to do what? To pass the test. So going back to hematology abbreviation terms: RBC, red blood cell count; HB, hemoglobin; HCT, hematocrit; WBC of course, white blood cell; platelet count; MCV, mean corpuscular volume; MCH, mean corpuscular hemoglobin; MCHC, mean corpuscular hemoglobin concentration. Listen, RDW, red cell distribution with neutrophils of course; lymphocyte, monocyte, eosinophil count. Those are all straightforward. Which one is an abbreviation? ESR, erythrocyte sedimentation rate; CRP, C-reactive protein. I'm skipping ferritin. Ferritin is ferritin. TIBC, total iron binding capacity. Iron is iron, of course. B12 is B12 as vitamin B12, and that is that. Now let's check out now in a broad sense what hematology lab means, and how to critically think about it on the exam, and of course how to quickly understand it and what things really mean. And that is it. You can be seeing the number as a provider and not know what it means. Let's listen here. Exam is fair in that sense. Any entry level exam, you have to at least know what things mean. You have to know how to critically think about it. So if they give you questions regarding them, you also have to knock it out. Let me tell you something again. You have to know 140 diagnoses to safely pass this exam. Minimum, you have to know 100 diagnoses to pass your FMP, AGMP, AGACMP exam. You have to know what again? Minimum 100 diagnoses, okay? That is one part. Now you have to know a lot of labs. That is another part. Another part is you have to know 14 whooping body systems. So I want to encourage you today that you are not stupid. If you find yourself here, you're still trying to pass the exam, you can't get your hand on it, you can't wrap your head around it, it is a tough exam. It's a lot of content. Does it make sense? Again, I always said in my previous videos too, the drug-drug interaction, the food-drug interaction, the drug-disease interaction, and all. We're not even in pharmacology yet. We're still doing assessment and diagnosis, and part of our assessment is this lab. And that is why things are launched in Canvas. I promise I'm not trying to dump on you. What you must not do is this, though. After signing up on www.mpcertificationacademy.com, stay committed to that. Don't jump from review to review. Stay focused and make so many rounds within the Canvas. You're going to be fine. 6 students just passed. You will pass too. Okay, now let's dive in to hematology. Again, speaking as Dr. Kehinde Elisha, founder of MP Certification Academy. To reach us, nurse-to-nurse-coach@gmail.com or call 347-901-6037. So when we talk about hematology labs, let's talk about WBC first. Okay, what does that mean? First is the total number of white blood cells in the blood. Now, what is the normal range? 4,000 to 11,000 microliter. Now, what does it really mean? When we have a high number, it means infection. We saw the same thing with our immunology, similar, right? So I won't really spend too much time with the same thing. Decrease means bone marrow suppression and all that. IWBC with fever, likely there is an infection. Low WBC on chemo, that means they have risk for neutropenic precautions. Okay, that would be the critical thinking application of it. Okay, now what about RBCs, red blood cells? Of course, number of red blood cells, right? In male, we expect the range to be like 4.6 to 6.1. In female, we expect it to be like what? 4.2 to 5.4. Okay, RBCs is the next thing that we're going to talk about. So in male, RBCs 4.7 to 6.1, female 4.2 to 5.4 million microliter. If it is low, we know that is anemia. If it is high, we know it's polycythemia. Don't worry, you will get this content too. Okay. Now, decrease with fatigue and shortness of breath. Consider iron deficiency anemia. Now, what about hemoglobin? We know that, the main definition for it is going to be like it's an oxygen carrying protein in the RBC. That's the purpose of hemoglobin. And that's why when hemoglobin is low, you find people like they're short of breath and stuff like that. So in male, the range is slightly different. It's okay to be 13.5 to 17.5. In female, 12.0 to 15.5 gram per DL. And then it is low in somebody with anemia, or if they lose blood for whatever reason. It is high in somebody with dehydration or polycythemia. Now, if hemoglobin is less than 7, transfusion is definitely necessary, but not for everybody too, though. Some people, they chronically stay here, okay? And we also have other cultural things to consider with our, Jehovah's Witnesses, and that is a different topic for another day. When somebody's on high altitude, you better expect the hemoglobin to be high. When hemoglobin is high with a high altitude, that's what they call, the blood just becomes so thickened. So that's not a good thing too. When it's too high, like excessively high. So that means if the blood is so thick, it's not going to flow through the vessels easily. It's going to be tough to get it out to the organs. What about hematocrit? Percentage of blood volume made of RBCs, and helps with clotting. Male 41 to 53%, female 36 to 46%. Mirrors hemoglobin, decrease in anemia, increase in dehydration. So you want to use mirrors hemoglobin means just look like it. Hematocrit, hemoglobin, they kind of seem to be the same thing, right? Different tests, different ranges and stuff. But if it's also down, it also means anemia. If it's also high, it can also mean dehydration, which is very similar to what hemoglobin looks and sound like too. So if you know one, you kind of know the other. You want to use hematocrit to confirm anemia or fluid status. Now let's take a look at platelet count. Now our platelet, what does it do? It helps us with clotting, right? What is the normal range? 150 to 450 microliter. Now, we now have, if it is low, that means there is a risk for bleeding because there's nothing to clot you. If you get hurt or something, so you can continue to bleed and bleed and bleed. And aka thrombocytopenia. What about if it is increased? We're gonna have clotting risk, and we may have what? Thrombocytosis. So make sure you know those two differences. If platelet count is low, we may have bleeding risk, thrombocytopenia. If we have platelet that is high, we may have clotting risk, like thrombocytosis. So less than 50,000 is bleeding risk. You want to avoid any kind of invasive procedure because they will never stop bleeding. More than 450K, you want to rule out what? Myeloproliferative disorder. The next lab is MCV, that is mean corpuscular what volume. Average size of RBC is 80 to 100 FL. Decrease in what? Microcytic, that's iron deficiency. Increase in macrocytic. So MCV is low in microcytic. It is that's what we have iron deficiency, anemia, and then we have increase. It is increase. MCV is increase in macrocytic, where we have B12 and folate deficiency. Pay attention to that. It's gonna be on your test. Okay. Now, what about MCV guides or frequently tested is what I should say. MCV guide types, anemia, essential for diagnosis. What about MCH or MCHC? Hemoglobin content in RBC. MCH 27 to 33 pg, MCHC 32 to 36 gram per DL, and then decrease in somebody with what? Hypochromic anemia, Fe deficiency, which is iron deficiency, hypochromic anemia. It is increased in somebody with hyperchromic anemia, like spherocytosis. Now, what about you want to use with MCV to characterize anemia? That's the critical thinking application of that. RDW, that's the red cell distribution with variation in RBC size, 11 to 15 to 14 to 40 to 14.5%. Increased, if it's increased, mixed anemia or early anemia. Now, IRDW plus low MCV, you got to think iron deficiency. Now, let's talk about reticulocyte. With reticulocyte count, immature RBCs is 0.5 to 2.5%. Increase is equal to response to to blood loss or anemia. Decrease is due to bone marrow failure. Listen, increase of reticulocyte count means there is response to blood loss or anemia. A decrease will mean what? Bone marrow failure. And we want the level to be between 0.5 to 2.5%. So a high retic count means bone marrow responding. Low retic count means what? Aplastic anemia. I know this sounds like a torture right now. You need this foundation to get through your exam. Stop gambling on that exam. Get on this content. Solidify your foundation. Solidify your patho, your form, your assessment, your diagnosis. You would not go wrong. You need the right review, and you are in there right now. So just stick with this content. Trust me, you're going to be fine, because this is not going to be a shock to you when you get to the test. Now, what about ESR? Erythrocyte sedimentation rate. Non-specific inflammation marker. In male, it is less than 15. In female, it is less than 20 millimeter per hour. When it goes up, it means there is infection going on or some kind of autoimmune diseases. Generally used to track autoimmune like lupus, like RA or temporal arthritis. We're going to move on to the next one. Peripheral smear. Microscopic exam of blood cells. It detects shape, abnormalities, sickle, sphetocytes, blasts. Abnormal smear will mean that they have leukemia. Hemolysis, further workup is generally required. In iron studies includes what? Serum iron, ferritin, TIBC, varies ferritin, right? That means we don't have like a normal range or abnormal range, it just varies. But the range is generally from what? 12 to 300, because that's a big variation right there. So if it is down though, decreased iron or ferritin means we have iron deficiency. If we have increased ferritin, it means we have some kind of inflammation or acute phase reactant. All right. Now, ferritin is best indicator for iron deficiency unless inflammation is present. Now, what about vitamin B12? Folate is needed for RBC production. Now, for B12, okay, we want the range to be from 200 to 900 pg per ml. For folate, we want it to be more than 3 ng per ml. If it is low, it means we have macrocytic anemia. Neurologic symptoms. Alcoholic with macrocytic anemia. Check B12 and folate. Now, real life critical tip. How do you want to think about this? Listen, if your hemoglobin is low in real life, you want to ask, is MCV low too or high? If MCV is low, you know it is iron deficiency. If it is high, you know We have B12 and folate deficiency or alcohol abuse. I will say that again. How do you critically apply this in real life? You need your critical thinking skills to be able to pass your what? Your FMP, AGMP, and AGACMP exam. There is no other way. Or even your PA exam, whatever you need these labs for, you must be able to critically think and apply this. They won't just give you those labs and words directly. If hemoglobin is low, you want to ask yourself, is MCV low or high? If it is low MCV, you know it is iron deficiency anemia. If it is a high MCV, you know it's B12 or folate deficiency or alcohol abuse. If platelets are low, you want to assess any petechiae, bleeding gums, recent infection, or medication use, heparin, antibiotics, and so on and so forth. You want to assess that. All right. Now let's talk about serology. We just finished what? We just finished hematology. So what are the concepts under hematology that we discussed? It is WBC, it is RBC, it is hemoglobin, it is hematocrit, it is platelet count, it is MCV, that is the mean corpuscular volume, it is MCH, MCHC, it is RDW, it is ESR, it is iron studies, vitamin B12, and that is it. Now we're going to dive into serology. What are these serology terms that we need to know? Have you noticed that for each concept, my immunology was 15 or 16 minutes. My hematology was 15 or 16 minutes, 15 minutes to be exact. Now serology, I will keep it under 15 minutes because we just went through a really large content, okay, prior to here, right? So now serology, which of course I was able to bring that one to life. So I hope you understood your serology. I need some yeses in the chat if you understand your serology. We're not going to spend too much time on this one, okay? But what are the terms? What are the key things we need to know though? Serology, antibody, antigen, titer, agglutination, precipitation, complement, direct Coombs test, indirect Coombs test, seroconversion, immunoglobulin G, immunoglobulin M, immunoglobulin A, enzyme-linked immunoassay. Those are the terms that we need to know for what serology. Tell me, you walk into a Elisha, you're thinking, well, are you seeing Dr. K's? Are you seeing Dr. K in the Elisha's name or what? Honey, that's what's going to feel like. That's what happens when you don't prepare. So you got to prepare. You got to really know these things before you walk into that test. So let's get down to it, just the definitions of it. Serology, how do we define it? Is the study of serum and immune responses, especially antibodies and antigens. Listen. Antibodies, I always say they are the bodyguards. So remember, I was giving examples earlier. They're like your bodyguards, right? Now, antibody, protein produced by immune cells that bind specifically to an antigen. Antigen, what is it? It is a substance that triggers an immune response, usually a protein on pathogens. Titer, it's a measurement of antibody concentration in serum by serial dilution. Agglutination, clumping of particles, cells, or bacteria caused by what? Antibody-antigen interaction. Precipitation, formation of an absolute insoluble complex when soluble antigen and antibody bind in optimal proportions. Complement, blood proteins that enhance antibody effect, leading to what? Pathogen destruction. What about direct Coombs test? Test detecting antibodies or complement blood directly to red blood cells. What about indirect Coombs test? Test detecting free antibodies in serum that can bind to red blood cells. Seroconversion, time period when antibodies become detectable in blood following infection. Immunoglobulin G, the most abundant antibodies type in blood, provides long-term immunity. Immunoglobulin M, first antibody produced in response to an infection. Immunoglobulin A, antibody found in mucous membranes like saliva and respiratory tract. Enzyme-linked immunoassay, ELISA, a test that uses enzymes and antibodies to detect presence of antigen or antibodies. It is what it is. Exam is a definition of stuff. Do you understand your concept? That is what it's about. That is what this is about. Before we get into the full serology again, these top ones are important to me. Please, so ANA, anti-nuclear antibody, detect what? Autoantibodies against nucleus. It's negative or less than, actually we saw this earlier anyway, in our main content. That's what we want it to be, negative. If it is positive, That means there is an autoimmune disorder going on, right? If patient has joint pain, rash, fatigue, and positive ANA, you better consider SLE. And you know that will be a test question right there. You better follow with antibody, anti-dsDNA, and ENA panel. Now, what about RF rheumatoid factor? Antibody found in rheumatoid arthritis. Generally, we want it to be negative, less than 14 IU per ml. If it is positive in RA, S0 and SLE, joint stiffness, is what is seen in the morning. If you see this in the morning with positive 2 plus RF, rule out RA first, and then you want to order anti-CCP. You got to know the order of stuff in primary care or even in acute care settings. You must know the order of how things are ordered, okay? Now, what about anti-CCP? Cyclic what? Citrullinated peptide. It detects antibodies specific to RA. Generally, we want it to be negative. It is positive in early RA. It is more specific than RF if RF is positive, but symptoms unclear. Anti-CCP confirms diagnosis. What about hepatitis B surface antigen? It means there is an active hepatitis B infection going on. You better know this, what it means. Know these definitions. This is my priority, everybody. I need you to know what these things mean first before we can even dabble into questions. Because you're going to go into that question just memorizing answers, and those questions will never show up on your test word for word. There are no strategies without content. Absolutely none. Listen, that is my watchword. I oversing it actually. No strategy without content. Absolutely none. So hepatitis B surface antigen means there is an active what? Hepatitis B, just like we discussed earlier when I tried to kind of bring it through my clinical simulation as I was drawing on online, and I hope you were able to capture that. We want the answer to be, we want this to be negative. If it is positive, something is fishy. There's an active infection. If patient is fatigued or jaundiced, you better check LFTs and HBS AG to confirm viral hepatitis. Now, with hepatitis B surface antibody, it means immunity. It is on the surface. The police will stay on the surface to protect us. See, it means immunity post-vaccine or infection, right? So if it is positive, more than 10, that's what we want. If it is negative, that means you lack it. That means you don't have a police protecting you. It is used to check vaccine response, low titer. You have to consider booster. Hepatitis C antibody, it detects HCV exposure. Negative is what we want. If it is positive, it means there is past or what? Current infection. Antibody, anti-HCV. So look, if patient has IV drug history, that's what they're going to put on your test as well. They will tell you somebody's having IV drug use, okay? And that is what you're going to, then if it's also elevated LFTs, you better be checking anti-HCV. Then you want to confirm it with what? HCV RNA. You got to know that 100%, okay? Now look at HIV half antigen and antibody combo. It detects HIV infection early. Then of course we want it to be negative. If it is positive, HIV infection is ongoing. What will you see? What will they report? They will tell you they have unexplained weight loss, chronic infection. You want to order HIV test. You want to follow up with what? Confirmatory tests. Okay. Monospot, heterophile AB test. It's a rapid test for EBV mono. It's generally, if it is we want it to be negative. Generally, if it is positive, it means they have mono. They are positive for mono. Monospot for mono. Teen with sore throat, posterior lymphadenopathy. This is generally your common scenario. A teen with sore throat. You know, another name for mono is kissing disease. So you can connect that with teens too, right? So you want to order monospot. All right, so we're now going to move on to RPR, rapid plasma raging, screens for syphilis. Okay, we want it to be non-reactive. If it is reactive, it means they have syphilis, and we have to follow up with FTA to ABS. So new rash, what would the patient complain? They will say they have a new rash on palm, soles, or genital ulcers. You want to screen with RPR, confirm treponema test. What about CRP? C-reactive protein inflammatory marker less than 3 milligram per L is what we want. If it is higher than 3, we know there's an acute inflammation or infection going on. If patient has joint pain plus ICRP, likely active flare or infection, track treatment response. Now, what about ESR, erythrocyte sedimentation rate? marker of chronic inflammation. Less than 20 millimeter per hour is what we want. But if it is high in RA, TB, or temporal arthritis, if it is high, sorry, we know we have RA, we have TB, or we have temporal arthritis. Sorry for my typo there. Now, if a patient comes in and they start saying, hey, I have a headache, scalp tenderness, and then you now check ESR, you see a high ESR, you may want to go ahead and consider temporal arthritis. You have to refer ASAP. So critical thinking tips, then always correlate lab result with symptoms on physical exam. If screening test is positive for RPR and ANA, you want to confirm with specific tests like FTA, ABS, or anti-dsDNA. Be alert on false positives or negatives. Example, RF can be positive in elderly. Use trending monitoring like CRP, ESRs in chronic inflammatory diseases for management. That ends our lab on immunology, hematology, and serology. But I'm going to quickly just wrap my serology up by, calling out the list like I did for the others. So ANA, anti-nuclear antibody. RF, low rheumatoid factor. Anti-CCP cyclic citrulinated peptide. Hepatitis B surface antigen. Hepatitis B surface antigen antibody, anti-HBs. Hepatitis C antibody, anti-HCV, HIV, AF, antigen and antibody combo, monospot heterophile A/B tests, RPR, rapid plasma region, CRP, C-reactive protein, ESR, erythrocyte sedimentation rate. That ends our review of labs. All right. Dr. Kehinde Elisha speaking here, founder and CEO of MP Certification Academy. To reach us, nurse-to-nursecoach@gmail.com or email or visit www.npcertificationacademy.com. We have exam reviews. You can be guaranteed to do well. This is just 1/10 of our content, okay? So we have a lot more content in Canvas and that we teach. Audios and slides are released. You don't have to fill in any gaps. You have complete notes. You're going to engage. You're going to meet twice a week. Real human here. Human touch twice a week. You can be that. We look forward to seeing you in class. Go visit www.npcertificationacademy.com or call 347-901-6037. Thank you so much and have a wonderful day. Bye-bye.